Dr. Gabriel, what do you think is most driving pneumonia deaths in places like Somalia today?
Yeah, thank you very much. It's great to be here. I think we all work in fragile settings. There are lots of things we share, which are common to all fragile settings. But I think Somalia probably has its own uniqueness. I would probably emphasize a little bit on that one. Our minister has said it all, which makes my life easier. However, just to mention a few, Somalia has suffered from 3 decades of protracted conflict, compounded by recent climate change challenges, with a bizarre combination of droughts in one place and then flood in another place, and so on and so forth. Yeah, conflict is one thing, but it's compounded by a number of other challenges. Due to those factors, I think displacement is very high. Probably when you compare to many other countries, the figure which the minister mentioned, 2.6 million, families, people displaced out of a population of 30 million is nearly 20% of the population living in IDP settings. Some IDP settings are there for nearly 20 years, so on and so forth. And then that comes its own also challenges of overcrowding, lack of access, and so on and so forth. No other country does have that number of displaced people. If you look at the per capita kind of displacement, and then IDPs have also, sometimes it's better to be a refugee because you get a kind of protection according to humanitarian principles. They don't get those. So that is one thing. Of course, due to the conflict, a number of health infrastructures have been destroyed. In our recent service availability and readiness assessment, out of 1,100 health facilities of Somalia, around 500 are still within Al-Shabaab occupied territories, and the ones which are also in the liberated areas don't function properly. It's very much symbolic structure and so on and so forth. So this would mean access and also quality of service for to treat child illnesses will be compromised. Just one more thing, I think when you talk about pneumonia, most countries were talking about contribution of pneumonia to under 5 mortality. Yesterday is like 20%, 19%. In Somalia, it is as high as 25%. It's staggering. In 2015 alone, we lost 15,000 children to pneumonia. That is like 2 deaths per hour. But no, not everybody talks highly of Somalia because our population is very small, and I think donors and everybody else is focusing on big countries with a huge burden. I think that we believe is not fair, and we have become a victim of that small population size.
Mm-hmm. We know that pneumonia progresses incredibly rapidly. Especially those of us who are clinicians in the room have seen in a matter of hours just how devastating this disease can become. And so one could say that to cure deaths from pneumonia, we really have to cure delays in treatment access. And so I'm curious, Dr. Gabriel, if you could talk about what you have seen work to shorten the time from symptom onset to effective diagnosis and treatment access in your context in Somalia.
Good, yeah. So, we've been discussing about challenges, also more specific challenge of Somalia, because there are some uniqueness, as I said earlier. I'm jealous, when people talk about PCV and so on, because we have not been eligible to PCV vaccine, where other, fragile states were. And that has to do mostly because of the burden thing, which we don't really contribute much to the, to the world. But all is not, challenges. There are good success stories. The minister has mentioned the figures in terms of reduction. We have achieved along maternal mortality, child mortality, so on and so forth. I think in such circumstances, we have to definitely design a very innovative, high impact, low cost intervention. Specifically things like ICCM, which is Integrated Communications Management. It makes a lot of sense to scale up ICCM in fragile settings because health facilities are sparse, and in a context like Somalia, which is a very, one of the least densely populated country, population are settled in different places. And then the average distance for most communities to walk to the nearest health facility is 6 to 8 hours. So there are also, apart from the geographic barrier, there are financial, cultural barriers, and so on. So then what do you do if communities cannot access health facilities? We should be able to take the service to the communities. So one best platform to do it, that is ICCM. It is very cheap. It would cost you probably $5 to $6 to treat a child with ICCM approach. To treat pneumonia alone, we've been saying yesterday, half a dollar. So this is very cost effective. It's also community driven. You train community health workers for 3 weeks, and then support them with supervision and so on and so forth, for them to be able to treat the 3 common illnesses: pneumonia, diarrhea, and malaria through an integrated approach. So, this is not a vertical approach, which have been mentioned yesterday. This is an integrated approach. With the support of Global Fund in 2017, we mapped out all ICCM interventions. We developed guidelines, protocol, we developed policy roadmap, and we've trained over 1,000 community health workers to be able to go to the communities and treat children. So in 2019 alone, we treated over 20,000 children.
Wow.
And it can be done in all such settings, and it makes a lot of sense, particularly in fragile settings, where low resource settings. So I think that is one key approach. We can't wait for PCV and prevention, but we could still do in terms of treatment, early diagnosis and treatment. Of course, community health workers, they need to be supported, and in case of complicated or severe pneumonia, there should be a means of referral linkage system to health facilities. So I really want to focus around ICCM and this scale.
People say, we are all saying, that it is hard to work, especially in these most challenging settings that we are all working in, and it is hard to stop pneumonia deaths, and yet we know how to do it. And so I'm curious if we could just kind of go down the line, and I'd love to hear each of you, if you could make one recommendation for how policymakers should make policy, or how funders should fund differently, or how implementers should be implementing differently. What would be the one thing that you think, based on what we know right now, could have the biggest impact on reducing pediatric deaths from pneumonia?
Yeah, basically, we have to invest in system, and health system strengthening in particular, because, I talk passionately about ICCM and community-led intervention, but this can't work if there is no strong system in the country. And Somalia, because of all the challenges it has faced for the past 30 years, has a very fragmented health system. I think that has to be supported from domestic resources plus, the support of communities. Just comment on ICCM. As a clinician myself, I was very skeptical about ICCM until I read the evidences. We have 25 years of evidence. UNICEF Save the Children, and I think the evidence of ICCM curving under 5 mortality up to 70% is there, and the evidence are overwhelming. I think I just don't want us to leave this room with contradictory messages. So yeah, it works, but it can't work alone. It has to be linked to health facilities and system.